Arterial hypertension. My lecture will be depicted to definition of the pathogenesis, risk assessment, diagnostic tools, and the treatment according to contemporary clinical protocols for arterial hypertension patients. I congratulate on the beginning of the new semester, and let's get down to business. So the first slide is depicted to definition of arterial hypertension. The hypertension is defined as abnormality in blood pressure above normal ranges and a progressive cardiovascular syndrome that associated with high cardiovascular risk that related to target organ damage and often presence before high BP values that observed. Please take into consideration the term of hypertension is associated with either systolic blood pressure elevation or diastolic blood pressure elevation or both. So-called diastolic and systolic blood pressure elevation, the chronic hypertension should be taken into consideration for further consideration. The rise both of systolic and diastolic BP is the main factor contributing to increased cardiovascular risk. Despite of the rise of systolic blood pressure, results significantly rise diastolic blood pressure, in turn this accelerated arterial hypertension and can be associated with greater risk than accelerated rise in diastolic BP. On the next slide, you can see the prevalence of arterial hypertension worldwide. Please take into consideration that arterial hypertension are equivalent present in men and women populations and both other populations, and it is crystal clear that arterial hypertension is age-related disease. So on the next slide, you have the great opportunity to recognize the interrelation between arterial hypertension and the cardiovascular risk elevation. In Ukraine, 14 million people demonstrate the clinical signs of some disease directly associated with elevated on BP. In US, 70 million people as well are qualified in patients with established arterial hypertension. So, moreover, most of them can associate with other comorbidities in other stage will directly increase the risk of death. The BP relationship to risk of cardiovascular disease is continuous, constant, and independent of other risk factors. That's why today the BP or arterial hypertension is determined as the most common cardiovascular risk factors. Each increment of 20 to 10 millimeter mercury doubles the risk of cardiovascular disease across the entire BP range, starting from 115 and 17 for systolic and diastolic respectively millimeter square. So, what causes can be reported for arterial hypertension? For more than people, with 95% of the cases have no primary identifiable risk factors, and the primary reason can be referred as the primary reason of elevation of BP. For all these cases, the essential hypertension is the term should be defined generally. For some people, the less than 5% of having hypertension from the underlying renal and lung disease and other causes, which can be identifying these patients. For these cases, arterial hypertension should be qualified as secondary. Essential hypertension is the term is the equivalent of primary hypertension. Essential hypertension results from the interaction of some environmental factors and genes. For instance, the diet, physical inactivity, stress, alcohol consumption, some drugs due to some diseases and the comorbidities including diabetes mellitus associated with genetic factors account for approximately 30% of the variation of the blood pressure across general population. All these factors contributing to elevation of BP in general population and correspond to increased cardiovascular risk personally. On this slide, you can see the pathophysiology principles of arterial hypertension. Pay attention, the essential and secondary hypertension might have non-identifiable and identifiable etiology respectively. Essential hypertension is associated with some process and their abnormality in peripheral artery resistance and increased stroke volume in the blood that may be related to either the following: inappropriate retention of salted water in increased endogenous pressure inactivity, or the so-called imbalance between pressure and depression factors that contributing to peripheral vascular resistance. Secondary hypertension can occur in the following conditions, as well as other: polycystic kidney disease, renal vascular disease, aortic coarctation, Cushing syndrome, and other. The main explanation is the secondary hypertension is disease in which we have great opportunity to identify potential factors which have causative relationship between the onset and the occurrence of arterial hypertension. If these factors is not potentially identifiable, please use the term essential hypertension. What kind of potential identifiable causes of hypertension? Sleep apnea, drug-induced or related causes, chronic kidney disease, primarily and secondary aldosteronism, renal vascular disease, chronic steroid therapy, and Cushing syndrome, thrombocytoma, coarctation aorta, intuitive parathyroid disease. A short list that includes some potential causes of hypertension, focusing on the primary reason. Pay attention to the primary reason that have causative influence on the occurrence of arterial hypertension is a principle for primary diagnosis in differential diagnosis for patients between essentially the primary and the secondary symptomatic arterial hypertension. Hypertension has very difficult pathophysiology mechanisms. Some molecular mechanistics are involved in pathogenesis of this disease. There are numerous factors contributing to pathophysiology of hypertension, including overactivity of circulating tissue, renin, angiotensin, aldosterone systems, sympathetic nervous system hyperactivity, insulin resistance as the primary and the secondary during diabetes and abnormality and abdominal obesity. Increased arterial stiffness, deficiency of overproduction of potential vasodilated substance, and the contrast, increased vasoactive substance deficiency, as well as nitric oxide, or increase the circulating level of endothelin 1, or the big endothelin so-called. The endothelin dysfunction, kallikrein system, and natriuretic peptides at some factors that contributed on the counteract to the pressure mechanism in arterial hypertension can have diminished activity and thereby lead to increased peripheral resistance. On this slide, you have the illustration of this cardiovascular continuum reported by Eugene Braunwald recently. And the slide illustrated some molecular mechanisms, the interrelationship between cardiovascular risk factors, including arterial hypertension at the beginning of the curve, at the end stage, organ failure and death. Please pay attention that the risk cardiovascular factor includes diabetes, arterial hypertension, the insulin resistance, can turn over the endothelial dysfunction and occurrence of other vascular disease and lead to some target organ damage that include maladaptive vascular remodeling and target organ damage, including chronic kidney disease. All these processes are resulting in end-stage organ failure and directly lead to death. The cardiovascular continuum is crystal clearly identified the potency of the cardiovascular risk, including cardiac hypertension, as the beginning of the tone pump that followed endothelial dysfunction and maladaptive remodeling that directly associated the risk of death. So, more closely for pathogenesis of arterial hypertension. Please pay attention that both factors, genes and the environmental factors contributing with each other might lead to at least 3 principal mechanisms. Defect in renal sodium homeostasis on the left side of the slide, defect in vascular smooth muscle growth in the structure that lead to maladaptive vascular remodeling, including vascular wall thickness on the right side, and functional vasoconstriction in the middle. So all these three main principles and the mechanisms that involve pathogenesis of arterial hypertension associate closely with vascular hyperreactivity. Because of some microvascular inflammation, dyslipidemia, diabetes, abnormality in regulation of lipid metabolism, thyroid dysfunction, and other factors contributing with each of them in the defective sodium hemostasis, vascular construction, and other, the vascular activity lead to totally vascular dysfunction and maladaptive remodeling. As a result, the cardiac output after regulation can diminish. That abnormality of total peripheral resistance leads to increased peripheral resistance, and both the factors led to increased BP value and manifestation of the disease called hypertension. So, to sum up, the hypertension is a result of combination of three factors. First of them, defect in sodium hemostasis. Second one, defect on vascular smooth muscle growth and structure abnormality associated with target organ damage. And third one, functional vasoconstrictions that can be temporary appear in the patient under some control of other factors, including environmental and genetics. On the slide, you have some possibilities to influence on some remodeling beyond of molecular substrate, some maladaptive remodeling. The central nervous system, the patient with arterial hypertension can get dramatic effect on cardiac vagus, sympathetic outflow, and thereby stimulate the synthesis and release of renin, and thereby the angiotensin and aldosterone hyperactivity as well. Molecular substrate associated with the vasopression can reverse of metabolism of kidney, and thereby this circle can be associated with increase of arterial blood pressure and associated with tachycardia and exaggerating sympathetic regulation of this one. So the main goal of this slide, we have seen the baroreceptors dysregulation associated with overactivity of central nervous system. Probably the baroreceptor mechanism can be involved in pathogenesis of arterial hypertension through some genetics abnormality. But arterial hypertension is defined as polygenes disease, and the baroreflex overactivity is only one the factors contributing to our exaggerating increased central nervous system hyperactivity. So, the final result of central nervous system that associate with overactivity of sympathetic system and renin-angiotensin system is closely associated with low baroreceptor activity. There is some speculation regarding that atherosclerosis that manifested in aorta can diminish the activity of baroreceptors as well, and thereby contribute to increase the role of central nervous system through increased sympathetic hyperactivity that regulate the overproduction of renin. Probably this mechanism can be seen in the younger patients with essential hypertension. So sometimes in the younger patient, even in children, in adolescents with early atherosclerosis, for instance, the patient with family associated dyslipidemia, the central nervous system hyperactivity really can stimulate the increase the outflow in overproduction of renin activity. So, but it's the only optionally, not for applied for all patients with arterial hypertension, because the pathogenesis is of this disease is not unique, and for all patients should be not applied. So On the next slide, we have the RAS hyperactivity and arterial hypertension. Please take into consideration that between target organ damage, including kidney and vasculature in the brain, we have some tight interrelation through overproduction of renin, but not only in the kidney, in some tissue, as well as overproduction in tissue and circulation of angiotensin II and I, the active metabolite that directly stimulate the overactivity of vasculature and lead to vasoconstriction and increase of stroke volume. So both mechanisms are tightly related to increase BP and associate with increased BP as well. So, despite of neurohumoral active role of angiotensin II in regulation of arterial hypertension, angiotensin II can associate with other pleiotropic effects, including oxidative stress, inflammation, tissue remodeling, and endothelial dysfunction. Some molecular mechanisms that cooperate with angiotensin II overactivity and some target organ damage molecular mechanisms are reported on this slide. Indeed, angiotensin II can stimulate vascular permeability, increase leukocyte infiltration of the wall of vasculature, increase activation of signaling pathways associated with overproduction of inflammatory mediators that stimulate the proliferation of a smooth muscle of cells and the vasculature, and increase the deposition of extracellular matrix as well. So, in addition, angiotensin II can regulate the hyperactivity of platelet aggregation and directly lead to vasoconstriction and decrease the bioavailability of potential endogenous depressive factors, including nitric oxide. As a result, the oxidative stress and endothelial dysfunction, inflammation, and tissue remodeling are the main molecular mechanisms can accumulate the pathogenic effect of angiotensin II on manifestation of target organ damage in patients with established arterial hypertension. What's about nomenclature of hypertension? Today, we have at least two opinions of the argumentation of some experts from US in Europe. On this lecture, we have great opportunity to discuss for both opinions. So the first one is the nomenclature of arterial hypertension reported by US experts. According to these clinical protocols, BP categories, as presented on the slide, should be divided in two groups, and this is called normal and patient with a stage of hypertension. In normal formularity, BP category should be divided into two groups for normal and elevated BP. Please take into consideration for experts' opinion from US, the elevated BP category should never be reported as the stage of arterial hypertension. The normal BP category is for systolic and diastolic respectively less than 120 and less than 80 millimeters square. So for elevated BP category, some terms should be used for routine. 120, 159 for systolic and less than 80 for diastolic BP. So hypertension should be divided into stages. This stage should never be qualified as the consequently stage. By the way, sometimes in the majority population we have that changes the stage 1 to stage 2, but it's optional. So stage 1 should be defined when the diastolic BP is 130, 139, and diastolic 80, 89 millimeters per square respectively. For stage 2, BP should be defined as more than 140 and diastolic BP more than 90 millimeters square. For individuals with established hypertension, stage 1 and stage 2, experts reported some recommendation to be applied. The main aim of this recommendation is in decrease cardiovascular risk and improve survival. In contrast to US experts, opinion, the guidelines provided to the expert of European Cardiologists Society is based on an idea that we have more categories of the patient with elevation of BP. For instance, we have instead two grades, three grades, grades 1, 2, and 3, depending on the level of systolic and diastolic BP, qualified, and the rest. For instance, grade 1 hypertension, patient might have systolic and diastolic BP average 140-159 for systolic and for diastolic 90-99 respectively. Grade 2, patient might have the average of BP 160-179 for systolic millimeter square and diastolic 100-129 millimeter square. For grade 3, patient have more than 180 millimeter square and diastolic more than 109 millimeter square. Then we have the normal BP for diastolic BP and increased across all grading of systolic BP. In this case, the patient should be qualified as individuals having isolated systolic hypertension. What about category of BP? And in individuals with not having hypertension. According to current clinical protocol, the patient should have at least 3 categories of BP: optimal, normal, and half normal. Optimal BP is associated with systolic and diastolic BP less than 120 and less than 80 millimeters square respectively. For normal BP, this category should be qualified as 120, 159, 80, and 84 millimeters square respectively. The high normal BP is associated with increased systolic and diastolic BP in the range between 131 139 for systolic and 85, 89 for diastolic. So, according to US clinical protocols, all patients with BP should be qualified as the subjects with through and unthrough hypertension. What's the difference between these positions? The true hypertension is defined as the patient having increased BP above cutoff point, 130 for systolic and 90 for diastolic. What should we do with the patients having isolating increased systolic and diastolic BP at the visit to office of the physician? And contrast, not having the elevation of BP at home. For this clinical situation, it calls at white coat hypertension. It's non-isolated office hypertension. The main definition is on this slide. We can see that hypertensive by clinical office measurement and normotensive by home and ambulatory measurement. All these patients should be reported as those who are having white coat hypertension. In contrast, mask hypertension is synonym white coat normotension. A definition of this one is all these patients should be normotensive by clinic measurements and hypertensive by home and ambulatory monitoring. So far, between white coat hypertension and mask hypertension, we have a big difference. It makes a big difference regarding some methods to obtain the more result for blood pressure monitoring that get some speculation what type of hypertension are. What kind of strategy of patient evaluation should be used in routine? In the slide, you can see the clear recommendation regarding this question. The evaluation of the patient is established that hypertension has 3 objectives. A stable lifestyle identify other cardiovascular risk factors or concomitant disorders, comorbidities, and the multimorbidities as well that affects prognosis and guide the treatment to improve survival. Reveal identifiable causes of high BP if it's possible. Assess or represent the absence of target organ damage and the cardiovascular disease. Please establish a cardiovascular disease if it was not previously induced. What's subject assessment and the prior to other examination? Please remember about history and the symptoms in the patient suspected to arterial hypertension. Should focus on modifiable lifestyle factors to include weight gain, exercise, alcohol, drugs, tobacco use, and psychological stressors. Dietary consideration includes intake of sodium, calcium, magnesium, potassium, cholesterol. The symptoms, unfortunately, are not specific for patients with hypertension only. Frequently, the patient will demonstrate a headache, visual impairment, and some other symptoms. For instance, muscle weakness, leg cramps, nocturia, polyuria, dizziness, syncope, dyspnea, palpitation, tachycardia, chest pain, chest discomfort as well. So all these symptoms are associated with the clinically significance of target organ damage, and the patient not having them, the majority of individuals will be silent, unfortunately. And next slide, the subjective assessment of the continuum. Past medical history should be differently assessed. The inquiry about any past reading of elevating blood pressure and significance for other diseases, including coronary heart disease and the stroke, cardiovascular disease, diabetes, dyslipidemia, renal disease, gout, or asymptomatic hyperuricemia, the sexual dysfunction should be defined. For medical history, you have to obtain the complete medical history, including over-the-counter medications, the herbal descongestants, appetite suppressors, and the oral contraceptives, the cyclosporine, erythropoietin, and other drugs that directly influence on increased BP or can lead to increased cardiovascular risk as well. So, hypertension assessment. Today we have some principles to verify the elevation of BP. For office measurements, the auscultatory techniques is really important. In routine, they usually use it. Home blood pressure monitoring and ambulatory blood pressure monitoring are both methods used in routine to provide differential diagnosis between masked and white coat hypertension, or define whether the patient is a candidate for advanced antihypertensive therapy, or if you want to verify whether your patient has full control for antihypertension after initial prescription of some drugs. On the slide, you see the BP measurement techniques in office, ambulatory BP monitoring, and self-measurement. So please take into consideration the self-measurement is recommended generally for all individuals having cardiac hypertension. Even if this is the case when the patient might have great opportunity to measure BP and the complete diary, you will have the full information regarding the morning and the night BP values. But in office, sometimes we have some difference between values reported by the patients through measurements. Sometimes the self-measurement BP is less when compared with in-office measurement BP. The ambulatory and the home monitoring are recommended generally for individuals to minimize the effect of GP influence on to prevent getting nervous, for instance, on the patients after visit to the office, and sometimes to provide verification of the masked hypertension and white coat hypertension. The office BP measurement is based on the classic Korotkov method. It is auscultatory method is properly calibrated and validated over all countries. The patient should be seated and quiet for 5 minutes in the chair, feet on the floor and arm supports on the heart level. The appropriate site cutoff should be used for ensure accuracy, and other crystal clear requirements should be used to obtain the concise BP values using these methods. Please don't forget about it in using routine the Korotkov and the screening. Self-measurement of BP can provide incredibly important information on the response to antihypertensive therapy, improving antihypertensive therapy, innovating to white coat hypertension. Generally, home measurements of 130 for systolic and 80 for diastolic millimeter square is increased considered to be hypertensive. In contrast to the cutoff point optionally is higher, 140 and 90 millimeter. Home measurement devices should be checked regularly, and please be aware that home devices are appropriate to measurement for self-measurements of BP as well. So, ambulatory blood pressure monitoring is recommended generally for individuals to confirm BP elevation or provide differential diagnosis between some types of hypertension. On this slide, we have some devices which use in routine to provide a BPM. So, the main advantages of ABPM monitoring result are the profile of daily pressure rhythm in some patients with hypertension. We can see that the so-called normal, the deeper typical diurnal blood pressure rhythm. We can see on this slide this rhythm. The principally that mean value of BP in the daily period when compared with this specific period at night when the patient is asleep, they demonstrate the average between 10 and 20% the mean ranges. So this typical profile is defined as physiological or deeper. The most of patients having hypertension without severe target organ damages will demonstrate similarity in this file. Please take into consideration the daily profile is the powerful method to identify the risk of the patient, especially associated with increased risk of stroke and the cranial hemorrhage. So on the next slide, we have this called non-deeper profile associated with isolating increase mean values of BP at night and the moderate increase BP value at daily time. In this clinical situation, we have the incredibly increased risk of death at night period, and please pay attention that sometimes the patient having isolated systolic hypertension might demonstrate this similar profile at the night, and at daily period, the patient might not have increased BP. So theoretically, this patient, beyond the result of ABPM, should not be qualified as hypertensive. So it's underlined why extremely important to use in routine ABPM to provide differential diagnosis and verify whether a patient is candidate for antihypertensive therapy. In the next slide, we have the so-called hypertension profile association with incredible increase that both systolic and diastolic BP after influence on stressful factors on the right side in office. So this profile indicate that the patient beyond stressful factors might have a normal BP, and after influence on this factor, BP can increase and the patient should be mistakenly qualified as hypertensive. The big question whether the patient with isolated white hot hypertension should be treated the same as the other patient with chronic systolic diastolic hypertension. But generally, based on the new clinical guidelines, patient demonstrating white cold systolic and diastolic hypertension might have increased cardiovascular risk. It should be treated at the same level as other patients having hypertension. So, treatment. Before treatment, please pay attention on the overview our consideration further. Goals of therapy, lifestyle modification, pharmacological approach in the discussion of some algorithm according to new clinical protocols. The management for BP for adults, children, adolescents, and some pregnant women, for instance, and the follow-up and monitoring of safety and efficacy, which should be used in routine. So let's get started. The goal of therapy is defined as the following. The reduced cardiovascular risk and renal morbidity and mortality is the main goal principles that incorporate clinical guidelines. The main goal of the therapy of the patient having arterial hypertension is improve survival and decrease the risk of the death and increase well-being. Treat to BP less than 140 for systolic and 90 for diastolic in all patients, and optionally BP less than 130 and 90 for systolic and diastolic respectively. The patient at high risk of death and other patients having diabetes mellitus and chronic kidney disease, this estimated GFR less than 16 should be applied. Achieve systolic blood pressure goal, especially in adult person from any years of age. And please take into consideration that we should treat the senior patient having isolating systolic hypertension, having age 75 years old. So improve clinical outcomes, clinical status, well-being, and quality of life. The secondary goals for therapy should be defined optionally. So to sum up, the improve of survival and improve clinical outcome, improve clinical status, improve well-being, and improve quality of life are big four. The principles should be used in the treatment of the patient having hypertension. Prior to close discussion about medicine and the patient having arterial hypertension, please recognize that there are at least two types of the factors contributing to evolution, the natural evolution of arterial hypertension. According to WHO experts, all these factors are defined into two groups: the unmodifiable and so-called modifiable. Unmodifiable factors include age, the older than 55 years for men and 65 years for women, family history of premature cardiovascular disease. Please pay attention, the premature, the keyword is defined as the premature fatal cardiovascular events in men under age 55 or women under age 65. If your patient having this family history of the premature CVD, these unmodifiable risk factors can add to 1 point to risk score and probably should be translated this effect into qualification of cardiovascular risk factors. Other factors on the right side of the slide should be qualified as modifiable, the potentially modifiable. For instance, severe hypertension, cigarette smoking, obesity, physical activity, dyslipidemia or hypercholesterolemia, diabetes mellitus second type, or the patient having diabetes first type on diabetes might have the duration on aneurysm more than 30 years. The microalbuminuria or estimated GFR less than 60 millimeter minute. So, to sum up, the unmodifiable and modifiable factors are contribute the natural evolution of arterial hypertension, and so-called the modifiable risk factors influence should be diminished by your efforts. You should know that lowering blood pressure can reduce cardiovascular risk dramatically, and each 2 millimeter decrease in mean systolic BP, the 7 reduction of the risk of ischemic heart disease mortality, and 10% reduction in the risk of stroke mortality can be associated with. So, based on this idea, you have to choose the optimal strategy to improve clinical outcomes rather than the patient having established arterial hypertension. According to US experts, 10 years atherosclerotic cardiovascular risk estimation should be used. With the specific online calculator on the slide, you have the first list of this calculator. Please see the bottom and the free access of this calculator. You can use it. Please take into consideration the 10-year risk of atherosclerotic cardiovascular disease is categorized as the following. The low risk less than 5%, borderline risk is between 5 to 7.4%, intermediate risk 7.5 to 90.9%, and high risk, the all patients having this estimating cardiovascular risk above 20%. So the access of this calculator, the reporting by American Heart Association and American College of Cardiology is free. You can use, you can calculate the risk using your smartphones, laptops, and other devices. They're absolutely free. So in European Union and Ukraine as well, we usually use in routine the score risk estimation. In contrast to previous data with Framingham height assessment in the previous slide, the score chart is based on an idea, yet we have the great opportunity to calculate the cardiovascular risk in the patient with age between 40 to 65 in men and women, and the patient not having diabetes mellitus. Please pay attention that patient having diabetes mellitus should never be qualified as having risk based on score system calculator. To easily understand and recognize what kind of cardiovascular risk factors are, I propose you this slide. The risk categorization should be defined as the four verbs. Low risk, score less than 1% on the free or qualified. It's theoretically 0%. A moderate risk score is between 1 and less than 5 at 10 years of further cardiovascular events, including fatal and non-fatal. Further modulated by family history on the premature cardiovascular disease and coronary artery disease, abdominal obesity, physical inactivity, high density lipoprotein cholesterol, elevated level of triglycerides, social class, and new factors that incorporated recently in these clinical guidelines is a high sensitive C-reactive protein, the POO marker of inflammation, the non-specific marker of inflammation. High risk is qualified when subject having markedly elevated single risk factors such as familial dyslipidemia and the severe hypertension, and the score system point have average between 5% and less than 10%. And of course, very high risk, the patient having the following: established cardiovascular disease, type 2 diabetes mellitus or type 1 diabetes at target organ damage, patient with moderate to severe chronic kidney disease with estimating GFR less than 60 milliliter/minute, the normalization value, and score point more than 10%. Pay attention, the 10%, 5%, 3%, and other percentage are reported to be qualified 10-year categorization of cardiovascular risk. This is assumption that the patient will be died within some period, 14 years, for instance. The patient not having established cardiovascular disease should be qualified as the patient having some risk. If cardiovascular disease has been established previously, you should not additionally calculate the risk. This risk is very high because cardiovascular disease has established. So, next slide. Two consequent slides will be depicted to some non-pharmacological intervention the patient with established hypertension. So please take into consideration that both slides are reported by the opinion of the experts of European Cardiology Society. Some non-pharmacological intervention affect weight loss, healthy diet, reduced intake of dietary sodium, and enhanced intake of dietary potassium. On the slide, we hear some crystal clear recommendations regarding this clinical protocol, and the place you can see that the weight loss and healthy diet, including dietary pattern, is associated with a decline of systolic BP approximately less than 5 millimeters. And these goals are important in routine because the goal is ideal body weight, but aim for the at least 1 kilogram reduction in body weight for most adults who are overweight. Not necessary to provide some clinical recommendation to increase trend to weight loss more than 5 kilograms per 3 months. And theoretically, the optimal weight loss should be qualified as 3.5 kilograms per 3 months. Response. Reduced intake of dietary sodium can lead to decline of blood pressure. And of course, there are some clinical data that confirm that reduced intake of dietary sodium can improve the cardiovascular risk through declined BP and improved survival. This improved survival is associated with decline in the risk of cerebrovascular disasters, for instance. Next slide, you can see the continuation of the previous data. The physical inactivity and alcohol intake are qualified as the powerful factors contributing to nature evolution of arterial hypertension, and modification of them can improve survival. The aerobic and dynamic exercise can decline BP in average 4 to 8 millimeter, and isometric resistance might have associated with smaller result, the 4 to 5 millimeter declining. So the main principles of the extending physical activity affects predominantly aerobic exercise. Please use the recommendation as your routine clinical practice. The moderation of alcohol intake is associated with reduced alcohol for men less than 2 drinks daily and women less than 1 drinks daily, and this recommendation can be supported by some specific clinical trials that have been shown that a decline at the average 4 to 5 millimeters straight with improved nature evolution of arterial hypertension, of course, the decline of alcohol mortality at the average. On the slide, you can see that generally clinical recommendation, how should we treat the patient with arterial hypertension according to clinical protocol reported by JNC8, the US experts. Please recognize that adults with an elevated BP at the stage 1 arterial hypertension who have the estimated in-year cardiovascular risk profile less than 10% at the moderate risk, if you don't remember, should be managed with nonpharmacological therapy and have repeat BP elevation within 3 to 6 months. Please recognize that the same patient having over 10% of the higher should be managed initially with the combination of nonpharmacological and antihypertensive drug therapy. The cutoff point at 10% qualified as a cutoff point that divides the patient with moderate to high cardiovascular disease. So the main principles of this recommendation is based on the idea that patient having a mild to moderate cardiovascular risk, even when BP is highly normal, should never be treated with antihypertensive drugs, but non-pharmacological therapy can address them. In contrast, the patient having high risk, more than 10%, in the stage 1, of course, can be treated with antihypertensive drugs and their combinations. So the main clear position of the expert of JNC8 is now general. Next one. The adults with stage 2 hypertension should be evaluated by referral or as primary care provided with 1 month of the initial diagnosis, have a combination of non-pharmacological and antihypertensive drug therapy. The combination should include 2 and more drugs and can be initiated immediately after verification of the risk and stage 2 disease. And high repeat BP elevation should be done in the interval of 1 month. And repeatedly measurement of BP is recommended generally for all patients having stage 1 and stage 2 according to these clinical protocols. What's the difference in the patient's treatment strategy reported by the experts of European Union? We have specific clinical guidelines that have clear clinical recommendation around this. According to these clinical protocols, we have to implement some clinical recommendation based on an idea that some patients should never be treated in the equivalent, having the difference in the cardiovascular risk and target organ damage and absolute BP. If you can see on this slide, you have recognized that some patients having different grades of BP, that the grades 1, 2, and 3 are based on the different level at the rest of BP, of course. So, in fact, that our treatment strategy, according to treatment clinical algorithm provided by the expert of European Union, attribute of the both parameter, the risk of the patient calculated by some representation of the score system, and BP value. So, finally, we have the very clear table. So let's try to use this table for our routine clinical practice. For instance, if your patient has been qualified as the individual with stage 1 without some complication and not having other additional cardiovascular risk factors, and a BP of this patient measured at home and the visit to your office are systolic 135 and diastolic 85, for instance. This patient might have low risk. The same patient having diabetes, the same patient but having diabetes, should be qualified as individuals having moderate or high cardiovascular risk, depending on the confirmation whether target organ damage are occurred. The same patient after stroke, for instance, but having established ischemic heart disease, of course, should be qualified as individuals having very high cardiovascular disease. This is an example that illustrates how extremely important to use in routine clinical practice that additional factors contributing to modulation of the risk in the patient having the same level of BP. Our next presentation should illustrate the clear treatment algorithm based on the idea that pre-specified cardiovascular risk values are produced by you. As initial, the therapy is based on the components, or both components, pre-specified cardiovascular risk and BP value. So, high normal BP is average 130-139 for systolic and 85-89 for diastolic, with low risk and moderate risk and mild risk of cardiovascular disease. I candidate for lifestyle modification only. Your advice for lifestyle modification are welcome. And please consider the drug treatment in very high and high risk of the patients when they have additional information regarding the target organ damage, or probably this information will be available in the future. For this case, you have to recommend the patient the continued monitoring for this condition of target organs and the new information of the powerful tool to face your initiate some treatment even if the high normal BP is present. Patient having grade 1 hypertension, BP 140, 149, 90, 99 millimeter mercury. I candidate for lifestyle modification. Please pay attention that lifestyle modification advice should be reported for across all the stages for all patients, regardless of cardiovascular risk and the other target organ damages. This is the option. This is not option. This is general recommendation. So, but if grade 1 hypertension is defined, please immediately initiate drug treatment in the subject having high and very high cardiovascular risk with established concomitant coronary heart disease and other cardiovascular disease or renal disease or their equivalent. For instance, in the patient having diabetes mellitus 2 type, having stage 1 hypertension with left ventricular hypertrophy in macroalbuminuria is the candidate for immediately initiating the set in the therapy with combination, the dual combination with bar drugs. Drugs treatment is low moderate to this patient if low risk is established. Without cardiovascular disease, renal disease, and other diseases that contributing to target organ damage should be reassessed in the period 3 to 6 months for lifestyle intervention and efficacy of BP therapy, of antihypertensive therapy. For grade 2 hypertension with BP average 160-179 for systolic and 100-109 millimeter mercury for diastolic, should be treated immediately with the combined treatment with 3 and both drug combination and triple combination are more optimal for the patient if they initiate the treatment. And the aim of the treatment is the tight blood control, and the new check out for this patient should be done in the period of 3 months, and please use it in regular manner to be aware whether the patient is being treated comfortably and safely. The grade 3 hypertensive patient with very high BP level should be treated with triple combination of some drugs, and BP control should be performed every 3 months by you in the office or in the hospital. So the previous combination of some drugs which should be implemented the patient that is having moderate and severe arterial hypertension is based on the idea that some drugs can potentiate the positive and beneficial effect each other. Previously, they had that some recommendations, very clear recommendations, for instance, some drugs that are recommended generally for the treatment of the patient with arterial hypertension. Thiazides like diuretic, angiotensin II receptor blockers, antagonists, calcium channel blockers, ACE inhibitors, and the beta blockers. All the 5 classes of the drugs are recommended generally for initiating the treatment. But nowadays, this scheme is now modified, and please take into consideration that all combination can be recommended apart from one, that angiotensin II receptor blockers with ACE inhibitors. This combination is absolutely prohibited for the patient with established arterial hypertension because of the high risk of chronic kidney disease and acute kidney injury as well. So please use other combination as you want, and adopt this combination for requirements of the patients and the safety, the tolerability for each components, but please refuse making some decision for combination of angiotensin II receptor blockers with ACE inhibitors. Contemporary initial protocol for patients with established arterial hypertension is reported on this slide. This protocol is prepared by the experts of the European Cardiology Society 2 years ago. For patients having it's called clear arterial hypertension without any comorbidities and some multimorbidity states. The main principle of this protocol is based on the idea that low dosage dual combination is obligatory better when compared with monotherapy. That's why to initiate the treatment, please use the combination at the early stage. So to initiate the therapy, please use dual combination. For instance, ACE inhibitors or ARBs. Please don't remember about refusing this combination both drugs. These are calcium channel blockers on diuretics. For instance, you can use the fixed combination ACE inhibitors plus calcium channel blockers, or ARBs plus calcium channel blockers, or ACE inhibitors plus thiazides like diuretics, or ARBs plus thiazides like diuretics, for instance. Next step should be done in some period according to these clinical protocols, the 3 months. Or if you have new information regarding not having control for BP elevation. These steps is based on the reported triple combination based on AC or ARBs plus calcium channel blockers plus diuretics. You can use the free combination of the drugs and the fixed and the non-fixed and adjust please the daily dosage and adjust please the components based on the monitoring of the safety and the tolerability for the patient for follow-up. The next step is step 3, is based on the use of the triple combination plus spironolactone or beta blockers if need. This stage is associated with an idea that probably the patient will not respond to a triple therapy, and as well as step 2 should be qualified that the patient having resistant hypertension. Resistant hypertension requires to be treated with spironolactone or other diuretics, alpha blockers or beta blockers. According to contemporary protocol, we usually use spironolactone as the next component and probably beta blockers as well. You can feel free of consequently adding spironolactone and then beta blockers, or in contrast beta blockers and then spironolactone. The main aim that the full control achieved for the BP of the patient should be performed. Beta blockers should never be qualified as the first-line therapy, antihypertensive drugs, and please use it in the class indication, including tachyarrhythmia or other increased heart rate in the patient with oral sympathetic stimulation and probably other reasons that are associated with increased heart rate. But these drugs should be added the obligatory component to improve the while the patient qualified as having resistant hypertension. Next slide illustrate the codification of this simple crystal clear scheme, the patient having hypertension to patient having combination hypertension, the coronary artery disease. And this clinical protocol, you can see that modification that the initiated a therapy, it makes a decision regarding the combination AC inhibitors or ARBs plus beta blockers or calcium channel blockers. Please take into consideration that in contrast to the previous slide, the beta blocker can be used in the first line of the patient having coronary artery disease. By the way, we can use the combination calcium channel blockers plus diuretics or beta blocker plus diuretics, but generally AC inhibitors, beta blockers, or calcium channel blockers are reported as more optimal for the majority of patients having this combination. What should we do if the BP control is not full? And the step 2 is based on the prescription of triple combination, the triple combination of above drugs, for instance, AC inhibitors plus beta blockers plus calcium channel blockers, or ARBs plus beta blockers plus calcium channel blockers, or AC inhibitors plus beta blockers plus diuretics. All these treatment schemes are reasonable, understandable, indecisive, and can be used in routine to achieve for control for BP elevation of the patient having combination hypertension and CAD. What's about resistant hypertension in this patient population? Spironolactone is discussed as the main component should be added, and the further component the triple treatment scheme. For instance, ACE inhibitors plus beta blockers plus calcium channel blockers plus thiazides like diuretics. If BP is not full control, please add spironolactone and moderate the doses 25 to 50 mg orally. So sometimes that resistance is not true resistance. Some patients can get a wrong report how they use some drugs, and maybe they have the dropout, the days and the diffuse of taking some drugs. So before verification of resistant hypertension, please recognize whether the patient is adapted to your treatment schema, can be used this treatment schema and follow up. Next situation is reported as the combination hypertension plus chronic kidney disease. What's the difference between previous treatment schema? The initiality of the therapy is based on idea dual combination ACE inhibitors or ARBs plus calcium channel blockers. We can discuss about beta blockers in this patient when we have some contraindication to RAS blockers, ACE inhibitors or ARBs. In this case, the beta blockers can be used at initial therapy, the first line, for instance. For next step, when BP elevation is not full control, please use triple combination based on the loop diuretics plus calcium channel blockers plus one of RAS blockers, ACE inhibitors or ARBs. What's about primary renin inhibitors? Theoretically, primary renin inhibitors can be used in the patient with chronic kidney disease in result of type 2 diabetes mellitus. But in real clinical practice, ASCVD is rarely used drug, which because of high cost and because of no large data that confirm large clinical trials of the safety and the tolerability of the patient having the declined GFR index. So nowadays, this combination that are ACE inhibitors or ARBs plus calcium channel blockers and diuretics are recommended generally for patients having hypertension and chronic kidney disease. To prevent the resistance of this therapy, please use spironolactone as well as the previous slide will be qualified. So, next situation is illustrate that the combination hypertension and heart failure. Despite of heart failure is not simple disease, the disease that have the specific phenotypes, that they have REF, reduced ejection fraction, they have PREF, preserved ejection fraction, in the often mid-range ejection fraction, that the patient with hypertension frequently have heart failure with the preserved ejection fraction. But no difference between treatment scheme the patient with hypertension without heart failure with preserved ejection fraction and the patient with hypertension having heart failure with preserved ejection fraction. But the treatment algorithm is based on the idea that the patient who have half REF and the heart failure with reduced ejection fraction might have some difficulty in the treatment. On the slide, we can see the specific approach of them. To initiate the treatment, please use combination ACE inhibitors or ARBs plus loop diuretics plus beta blockers at the initial therapy. The beta blockers are recommended generally for this position, and please titrate the dosage for a follow-up period step by step. Next step is to straighten the idea that ACE inhibitors or ARBs plus diuretics plus beta blockers might not have the benefit effect on reduced BP. If so, please add MRI, mineralocorticoid receptor antagonist. We usually use instead spironolactone eplerenone for this case. Pay attention that eplerenone and then more specify with high tolerability and safety in contrast to spironolactone mineralocorticoid receptor antagonist that are recommended generally for patients who have half REF, but not for patients who have half PREF. So that's why this clinical protocol is not required to use eplerenone in other patients having combination hypertension with other disease. But for individuals having combination hypertension plus half REF, eplerenone is recommended generally. What should be used in the patient with uncontrolled heart rate and atrial fibrillation having arterial hypertension? To initiate the treatment therapy, please use the combination ACE inhibitors or ARBs plus beta blockers, dihydropyridine calcium channel blockers or beta blockers plus calcium channel blockers. Please take into consideration that the patient with a combination hypertension and atrial fibrillation of water might have half PEF and half REF. What is this case? Please switch the treatment in the previous slide. No essential to produce this initiality of this therapy based on the idea that beta blockers with calcium channel blockers can be more optimal in the patient having half REF, for instance. By the way, for hypertension plus atrial fibrillation, this recommendation is appropriate. And if no full control for BP, please use the triple combination. AC on ARBs with beta blockers plus dihydropyridine calcium channel blockers on diuretics. Another combination, beta blockers plus dihydropyridine calcium channel blockers, all diuretics. So it's supposed to mean very difficult to remember and understand each treatment scheme according to European cardiology aside beyond all routine experience. I understand that please recognize that crystal clear and very simple clinical protocol provided by NICE. The NICE is Nature Institute on Health and the experts of the UK. So to produce clear recommendation of patient having cardiac hypertension, you should know only two positions: the age, younger and the older 55 years old, and race, white on other. So theoretically, when we have the young white man in the age of 40 years old, we can start the treat the patient with some antihypertensive drugs. The beginning of the name of it, they start with the letter A, AC inhibitors or ARBs, or ARBs in the principle. Avoid having combination of the drugs. For instance, AC inhibitors, Arterial, for example. If we have black and any age patient, please use calcium channel blockers or diuretics, thiazides like diuretics. In 3 months period, please check whether BP is full control. If no, add next stage. Next drug should be added to this treatment protocol. AC inhibitors or ARBs plus calcium channel blockers, or AC inhibitors or ARBs plus diuretics. In 3 months, if BP is not full control, please use triple combination. AC inhibitors or ARBs plus calcium channel blockers plus diuretics. It's a very simple treatment scheme, and I recommend you to use it in your routine at the first. Some words for resistant hypertension. What's about definition of resistance in hypertension? Resistant hypertension is defined as blood pressure that remains above goal despite of the current use of 3-hypertensive drugs at the maximum daily dosage, mediated for different classes. Diagnosis of resistant hypertension now require the exclusion of non-adherence to the antihypertensive drug regime and white-hot hypertension. A white-hot hypertension confirmation is required to be performing ABPM, don't remember about it, and non-adherence, the diagnosis of non-adherence requires to be executed the specific diaries that are completed by the patients. The self-BP measurements, the completing of diaries by patient, it's incredibly important to combine both data, the diary plus the data obtained from the performing of ABPM to confirm on the way the diagnosis of resistant hypertension. And what kind of cause of resistant hypertension are that? Improper BP management, excess sodium intake, inadequate diuretic therapy, some medication needing for other anti-inflammatory drugs that lead to fluid retention, for instance, excess alcohol intakes and other previously unidentifiable causes of hypertension. So sometimes if really this hypertension is through resistance, we have some degeneration system. It is a specific procedure like ablation procedure in coronary artery, in the cardio. So it includes the state-of-the-art generator and clinically approved multi-detector ablation catheter that you can see on the slide. And this procedure is recommended optionally, but not generally, for patients with resistant hypertension, but the effect is a temporary, for 6 or 8 month follow-up. What's about hypertensive crisis? There are some words of the difference. The hypertensive crisis is defined as markedly BP elevation associated with life-threatening clinical situation if they have the patient beyond them. Please avoid diagnostic of urgencies or crisis. Life-threatening clinical situation should be verified immediately after the verification markedly increased BP in the patient having some complaints. For instance, chest pain, chest discomfort, anorexia, dyspnea, and other. Please take into consideration that sometimes that eye symptom can be used in the difference in the practice. For instance, the hemorrhage in retina should be qualified as a sign of hypertensive crisis, but in contrast that hemorrhage in skin, for instance, should never be qualified in the crisis for the patient with marked increase of BP. What kind of drugs should be used in the context of the stable nature evolution of hypertension? On the slide, we have some approach that they use in routine for patients with established crisis. The main principles are first, use all drugs intravenously or sometimes sublingual. And next principle is please use very short list of the drugs. For instance, nitroprusside, labetalol, urapidil, or esmolol, and never use drugs. The effect of them should never be qualified as exact. For instance, diuretics. Indeed, intravenously taken diuretics can lead to uncontrolled diuresis. We should not prognosticate whether the volume of diuresis should be estimated of the patient in the follow-up. So, what's about pregnancy? The pregnancy is required to be treated. Hypertension as a pregnancy is required to be treated with a very short list of the drugs. And sometimes most often associated with chronic hypertension occurs with superposed preeclampsia. To prevent advance of the preeclampsia and the eclampsia, please check BP every day and perform the complete control for BP elevation for the treatment period. Please pay attention that some drugs are absolutely prohibited to use in the patient with a pregnancy, for instance, ACE inhibitors and ARBs, and some drugs can be used, for instance, beta blockers in the first 3 months of the pregnancy, and labetalol, for instance. And some drugs like diuretics theoretically can be used, but practically these drugs implementation is associated with worsening of fetal placenta factor survival, and please avoid using them. As an alternative strategy is methyl-dopa. Methyl-dopa is recommended generally in the patient with the high risk of preeclampsia. So please create a multidisciplinary team to completely assess the risk on the patient having cardiac hypertension in pregnancy, and after that choose the optimal therapy. So last slide for lactation in the women having cardiac hypertension. Some recommendation that I can execute for them. Little information on accession of agent in the breast milk and long-term effect of the exposed infants there. And please carefully peruse the recommendation they inserted in the box with drugs. And please use our qualified resource and open resource to be where there are no contraindication to use the drugs in lactation. The beta blockers, propranolol, labetalol can be recommended, but not data for calcium channel blockers. Diuretics can reduce milk volume and suppress lactation, and AC inhibitors in ARP should be completely avoided due the negative effects on the differentiation the tissue of the burns. So please, this slide should be missed. What's about the children in adolescents? Please take into consideration that the male principles of the treatment of hypertension in the patient, the children in adolescents, they're the same that should be applied for adults, with one exclusion of the rule. The inhibitors of RAS should never be prescribed for children, adolescents to prevent the negative effect influence on tissue differentiation. So please improve hypertension control and check adherence to the regime, provide this recommendation in regular manner, and prevent the onset of resistant hypertension and improve survival of your patient. So this strategy should be decline the risk of the cardiovascular mortality and create the empathy with your patients to maintain them on the way to improve survival in cooperation with you. Thank you for your attention.